Thank you for the nice introduction, and thank you for inviting me to speak. It's a pleasure to be here. As was mentioned, I'm a neurosurgeon at the University of Iowa. I specialize in treating Chiari, Syringomyelia, and complex disorders at the Cranio-vertebral Junction. I had a very fortunate training opportunity. I worked with Dr. Meneses as a neurosurgical resident for 7 years. And now I was really honored to work with him as a faculty member at the University of Iowa, side by side. So I'm going to talk about Chiari malformation or tonsillar herniation in association with these Osseoligamentous abnormalities at the Cranio-vertebral junction. Before I get to that, I'm going to kind of go over what the Cranio-vertebral junction is. And for those who don't know about Iowa, this is the University of Iowa undergrad campus. It's just across the river from the university hospitals. It really is a beautiful campus. And this is our new 14-floor children's hospital that will be opening up in about 6 months. This is the newest biomedical research building at the University of Iowa on the medical campus. And it's where I run a research lab investigating certain neurological disorders and neurosurgical disorders. So I have no disclosures. I do have funding from the National Institutes of Health and a K-12 grant. So what is the craniovertebral junction, otherwise known as the craniocervical junction? Is this fancy term that's used. Essentially, the CVJ, and that's how I'm going to discuss it because it's much easier to say, it's where the skull meets the spine. Okay, that's the most simplest terms. Now, anatomically, it's composed of the occipital bone that surrounds the foramen magnum, that opening from the skull to the spine, the C1 vertebra, or the atlas, and the C2 vertebra, or the axis. And that's just not it, though, because you have one of probably the most important aspects are the associated ligaments and musculature. And the CVJ contains and protects the cerebellum, the brainstem, and the upper cervical spinal cord, as well as the vasculature. So the occipital bone, located in the back of the head, and that basically encompasses the foramen magnum here. This is the clivus that's in front. This is an angle looked at from kind of the front and from the sort of the side. This is the front of C1 and the front of C2 here. C1 is also described and called the atlas in reference to Greek mythology, the atlas that was basically condemned to hold up the earth or the globe for eternity. So C1 does that. The occipital bone has these little bones here, they're condyles, and they rest right on C1. And what's important to note about that junction and that joint, so that allows basically 50% of your motion of flexion and extension. C2 here is also called the axis. It's called the axis because C1 and the occipital bone or the skull rotate on C2 through this little peg here. And it gives about 50% of your rotation of your head and neck. The CVJ has this complex joint configuration for us to allow these complex movements of the head and neck. But at the same time, this sophisticated arrangement predisposes it to congenital abnormalities, acquired abnormalities, and developmental abnormalities. This is just another view of it. Again, this is the condyle. You can see how it's not this flat in real life. It's kind of a ball and socket, so that you can get this flexion of the head. This is a side view, okay? About 50% of your flexion extension. And here you can see how flat the C1 and C2 joint is in this peg here. And this is a complete front view of looking at it. And this is flat here so that can rotate, okay? This is unlike any other aspect, any other part of the spine. And so why I mention these ligaments is that they're one of the most important aspects to the stability of the craniovertebral junction. That's what's holding basically your head on your spine. It's not a joint kind of locking like we see in the rest of the spine or other joints. It's literally these ligaments and this musculature that's doing that. And that's important to note because all the abnormalities that I'm going to talk about in some way have some abnormal ligament configuration in some way that has made them or will predispose them to instability. I'm not going to go over all the ligaments here, but you can see them. It's muscle that's lying on the back here, these ligaments here, but there's no bones here, as you can see. So why care about the craniovertebral junction? Well, one aspect, as I kind of mentioned today, the abnormal development of the CVJ could be an underlying cause of Chiari malformation. Hypothesis, that's hypothesis. And it helps us to understand these CVJ abnormalities and how they affect Chiari treatment. So craniovertebral junction abnormalities, what are they? Well, they're bone and or osseous, another term for bone and ligament abnormalities. Most of the ones I'm going to talk about today are all going to be osseous abnormalities. And these CVJ abnormalities are associated with Chiari 1 malformation. Not every single one that you see with Chiari has this, but some do. Okay. These CVJ abnormalities can then also be inherently unstable or predisposed to instability, and therefore the type of abnormality can dictate the treatment strategy for the Chiari malformation. So how does instability occur in the CVJ in the setting of CVJ abnormalities? Well, as I kind of discussed, the head, C1, C2, they're held together by these ligaments. If you have an abnormal structure that's there, if the bones haven't developed properly, your ligaments are going to be abnormal. They're not going to be as strong as they would in someone who has the normal development of the CVJ. So you have this abnormal ligament structure and arrangement that then predisposes to instability, and we're going to go over examples of those. Dr. Meneses is going to give a very long 1-hour talk and cover really the breadth of treatment for a lot of these conditions. I'm going to give you an overview of ones that we've treated at the University of Iowa and kind of give little points in here. They're going to basically start from kind of more simple to really the most complex. And this is the case that actually I did with Dr. Meneses during residency, I think in 2010 or so. This is a 27-year-old woman with autosomal dominant osteopetrosis. And so that's a condition where the bone it grows significantly. You can see the skull here, how thick that bone is. This is all bone, okay, on a CT scan, the sagittal view. This is about 2 inches thick of thick bone in the back of the skull, the occipital bone. You can see how thick it is here. And this is the MRI, the sagittal image. You can see how small this posterior fossa is because of how this extreme thickened occipital bone is pressed down and the tonsors have herniated. So you can call it a Chiari or tonsor herniation, a more appropriate kind of anatomical term. You can see it's compressing and pushing on the medulla here. This patient had occipital headaches, as well as swallowing problems. And so this patient was treated with it's a posterior fossa extradural decompression. So you can imagine trying to get through all that bone, pretty significant in time consuming process, but we did, and you can see how thick this is, 4 centimeters. The dura here, we did a complete C1 laminectomy, external excision of the epidural compressive band, and that external durotomy that really allows the decompression at that cervical medullary junction. The interesting thing about that and why we reported this and why sometimes case reports can be so beneficial is the fact that when we were looking, this is the first case that someone's ever treated with osteopetrosis and Chiari. But if you look at the radiology literature, many patients with osteopetrosis have tonsor herniation. Now, patients with autosomal dominant osteopetrosis, their symptoms are cranial neuropathies and headaches. And they're because the bone forms around these cranial nerves that are exiting. Well, what are your symptoms of Chiari? Cranial neuropathies and headaches. So we suggested that there's a possibility that some of these patients, a lot of these patients with osteopetrosis, may also be symptomatic from their Chiari as well. Those cranial neuropathies, depends on what location they are, but it may actually be occurring from their Chiari. And no one actually had really talked about that at the time. This is another abnormality in a 13-year-old girl. It's called a pro-atlas segmentation anomaly. And you kind of have to remember those images I showed you in 3D. This is the clivus here. This is the front of that occipital bone. Okay, this is an abnormal end development and congenital malformation of a bone that's protruding out from that. So she was developed and born with this. There is no odontoid here. The dens that's missing. You can see the compression that's put on the cervical medullary junction, how compressed this is, okay, and denting into this. Patient had pretty significant cranial neuropathies, and you can see how severe this Chiari is. And you can see the syrinx that's here. Dr. Meneses, he kind of pioneered the transoral approach, which is the approach through the mouth, to decompress something like this. The concern about doing if you just said, oh, this is just a Chiari, I don't really see this bony abnormality. If you do a posterior decompression, that symptoms may make it worse, but unlikely to really get a good decompression with this significant bony abnormality in front. So the treatment, again, for this patient was a transoral resection and posterior fossa extradural decompression. Then also, when you ever do the transoral, you'd have to do a occipital cervical fusion. You can see how great that decompression is by relieving that bony compression from in front. So this is another kind of ventral bony abnormality in a, I think, 34-year-old woman. This is an os odontoideum, which is basically a remnant of the second vertebra, the axis, the dens. It just forms a bone here. It's usually from trauma early on in life. You don't get that fusion of this bone to the dens. And these are basically inherently unstable. And this is the bone here in kind of 3D. Over time, this will fuse to this clivus, the front portion of that occipital bone. You can see the same thing, just similar to the last case, but a different abnormality, okay? Different etiology. You can see the compression here on the cervicomedullary junction, and then again, associated Chiari. Now, what is this? Are these ventral bony abnormalities decreasing the posterior fossa volume, and then they're having a tonsil herniation? Possible. Okay. So the same thing. A treatment for this is, again, transoral resection, going through the mouth. This is C1. This is the odontoid process, complete removal, and you can see the great decompression that Dr. Manisis did. So now we're getting into conditions that someone before used the term complex Chiari. It's a general term. I'm going to talk about the actual anatomical abnormalities that predispose these patients to instability. Not just, you can call it complex Chiari, but it doesn't really describe what's going on. So this is a patient with condylar hypoplasia. So that the condyles are those bones on the occipital bone that are resting on C1. You can see how small they are, right? There should be much bigger. See how flat that is, too. There should be a little bit more of a better ball and socket. So what is that going to potentially do? It can lead it to instability. There's really no much of a joint here. Basically, you're relying on all those ligaments. And the other thing that it does is that the whole spine then is actually higher up in development as it develops, because that condyles and C1 aren't the normal relationship. If this was bigger, the whole spine would be further down. And you can see this angle here is more acute. So some people may call this basilar invagination. The term basilar invagination, I'm not going to get into that, but they used X-rays to kind of determine what they called basilar invagination because they didn't have CT at the time. Typically, basilar invagination should be more thought to be where the actual odontoid herniates through that opening in the skull. Okay, that doesn't happen here, but it's still the same kind of concept where you have this indentation then and this compression at the pontomedullary junction, the pons and the brainstem and the medulla here, because the spine's so much higher in the development. And you also have a Chiari too, as a Chiari malformation as well. So for something like this, with this symptomatic patient, this pretty significant compression from in front, where in any position you could try is irreducible, meaning we can't take away that ventral compression in whatever position we want to do. Again, a transoral resection is done of that odontoid, that compression, and then a posterior fossa extradural decompression and occipital cervical fusion. So this is another case. It looks just like the last one, but different, okay? So again, you have this acute angle here, right? The clivus, the front of the occipital bone, and you have, this is the odontoid, the dens, and this is C1. Looks just like the last one, right? But it's different because this is the lateral aspect of C1. It should just look like the last patient, right? At least it should look like that. There should be a gap here where there's space where that joint is, but there is none because it's fused to it. So its atlas is C1. Assimilation means it's fused to the occipital bone. Remember I told you earlier that that's where all the flexion occurs, is at the occipital bone in C1, right? So if you have it fused, how are you going to flex? and extend your neck. Well, you have the rest of the spine. Doesn't that put a lot more pressure on the rest of the spine, right? Doesn't it put more pressure on that C1, C2 joint right here and here? Okay, so this patient may have some instability, but you can see there's compression here. And you can see the Chiari associated with it as well. Okay. So again, the treatment for this patient was transoral resection of posterior fossa, extradural decompression, and occipital cervical fusion. All right, now we're adding more things to it, right? So we have a case, almost looks like the last two cases. So we have, again, this is the dens. This is C1, but again, there's not that joint there, it's fused. So just like the last case, but you see this is a little bit higher up. This shouldn't be this high, it should be down here. And you see that gap there? It's too much. This is instability. And if you did a flexion extension, you would really see the instability. Because you put all that pressure on C1 and C2 now, and this is where all the flexion is taking place. So the ligaments here get weakened over time. And you get instability, you get this invaginating upwards, causing more compression superiorly. Again, there's a Chiari malformation and a syrinx. Okay? And this is basilar invagination, because you have that upward movement of that odontoid through the foramen magnum. And you have this horizontal, so it's like almost a horizontal and vertical dislocation. And you got the Chiari, so you have to treat all these things. So more recently, we have been going to different techniques in the operating room to try to do only a posterior reduction using sophisticated techniques and intraoperative instrumentation. And that's helped eliminate the need to do a transoral every time. Okay? But this patient did undergo a transoral, and then again, posterior fossa extradural decompression, and then occipital cervical fusion. So then this is a severe case of basilar invagination. This is a case of clipophile. So you have the atlas assimilation. You have that C1 fused to the occipital bone. Then you have C2 fused to C3. The more fused segments, the more pressure you're putting on that C1 and C2 joint for everything, for rotation, for flexion. And that's what the ligaments get so weak here over time with all the movements of the head of normal physiological life over time. That's why you get this significant invagination of the dens into the spine. And then you get the Chiari malformation, likely from maybe an abnormality back here, but also maybe reducing the posterior fossa volume. So this patient actually did undergo a posterior reduction only, did not undergo a transoral. The patient went to the operating room, were able to pull this aspect of the spine down and then do a fusion. And the last ones that I have, and there's many more, okay, of these kind of abnormalities, and Dr. Meneses can kind of carry on with those in his talk. Bacterial syndrome, and so you have multiple segmentation failures here in Chiari. I bring this one up because these segmentation failures isn't causing instability at the craniovertebral junction. This patient's probably not unstable at the craniovertebral junction. But you can see how flat the clivus is here. This is a young girl, 4-year-old girl. And how flat this is here too. And that's putting pressure on the pons and putting pressure here and causing this Chiari malformation, as well as this pretty significant syrinx. This patient actually was stable, so this underwent a posterior fossa decompression. So in conclusion, there are multiple CVG abnormalities that are associated with Chiari-1 malformation, or as Tim George said, probably a better term, tonsillar ectopia or tonsillar herniation, that dictate different treatment strategies. And better understanding of CVG abnormalities may lead to better understanding of Chiari-1 pathogenesis. So I want to acknowledge the American Syringomyelia and Chiari Alliance Project, and thank you for inviting me to speak. Really appreciate it. And to Arnold Meneses, who's been a mentor to me, and really want to thank him for challenging me as a physician, as a neurosurgeon, for inspiring me, and really treating every patient individually, both in the operating room as well as in the clinic. So, thank you.
I have a person who has a mild, one of those conditions where I have a very straight up neck in my x-ray leads a little bit forward, as well as some of those little drops and deposits there. Is there anything we can recommend or actually do to avoid that condition worsening through exercise or anything or other things?
It is very difficult to answer that question, right? Because, as Dr. Meneses and I were just talking, we really think it's extraordinarily important to see patients, talk to them individually, do a proper physical exam, see what is going on. Because it's these subtle findings that can really, really change what may ultimately I say to you. But it's hard to just, to give something without, I think, doing all that. So it's tough. Dan, answer that.
So no particular exercises to just in a broad sense to anyone to either recommend or avoid? So the imaging is important, right? Because imaging is important. I would have to see the imaging because in certain cases you can make things worse, right? If you have one of these as you're unstable, and by doing some exercises you could make things worse. Okay.
Thank you.
Sure. Yep, go ahead.
I'm wondering what you guys are finding long-term and the effects of the hardware-less intensive perfusions.
I'm wondering,
I think he may talk about it, but we've all talked about, him and I have talked about this a lot, and it depends on, so you mean in children, right?
Yeah.
Yeah. Every case is individual. Some cases that are young, they're unstable and they're getting worse, and you have to do a fusion. But that patient has to be watched for a long time because their skull and their spine is still growing, right? You fuse the back, but maybe their front is still growing and developing. So we have to watch that, and that's one thing that we do in those individuals. Nothing that we see with the hardware itself causes titanium typically, and nothing like that should cause problems if done properly. But the younger the kids, and I think he may talk about this, but less than 8 or so, they're fused, or 9, even 10. You still have to watch because they're still growing. The whole spine's growing. Their odontoid may still grow, and so they may need actually other procedures.
Say you've been seeing a chiropractor for a few years after you have been diagnosed, and
constantly tells you when you go in each week to have your neck adjusted that your atlas is out. Could that be a ligament instability?
So I've heard this,
Okay.
but I don't recommend chiropractor.
Well, I don't
yeah.
go anymore because it stopped working.
Yeah, they can't diagnose whether you have instability just
But he
on
could-
physical exam.
He could feel if the atlas is out by hand?
He could not feel it.
No. Okay. Thank you.
All right.
Any more questions?
Great. Thank you.